But I think we are good to start now. We have the full team from SHA. Director Koitaba is appearing twice, but one of the accounts is we shall see the face of Elijah Washira, CEO of SHA. The aim of this meeting is just to get the progress on the rollout for SHA, where we've reached, and also get clarifications from the questions we may have. As we all agree and know, rolling out a new system has its challenges, but they do not remain unsurmountable. So we are here to get the way forward on some of the hitches we faced, and also give feedback on whatever has worked, so that the authority can get that feedback as well. On the panel, we have my team from KHF, that is Charity, who's head of programs, and Martin, who's moderating the webinar. We have from SHA, also part of us is Liz Gitao from CAF, as well as Mkua from CHAC. If we have anyone who is in the executive committee of RUFA, please just raise or identify yourself on the chat so that I'm able to upgrade it to a panelist so that we can begin to field the first part of the questions for the webinar. The other people in attendance, we have Dr. Samson Kuhora from SHA, as well as Joseph Otieno and Wafula from SHA as well. Yeah, so that's the setup that you see. I receive my profound apologies for the delay in starting. We often pride ourselves in starting on time. So my profound apologies for the delay that we have seen. As a progress update, maybe Hazel, you could just in 5 minutes, just let us know where we have reached in the rollout, and we can begin to field some questions. Over to you, Hazel.
Thank you, Chairman, and good afternoon once again, everybody. Chairman, if you allow, in the meeting with me is our CEO of Social Health Authority, Elijah Washira. Kindly allow me to invite him to give us an overview. Thank you.
Much in order. Karibu sana, CEO.
Thank you very much. Good afternoon, everyone.
Good afternoon.
I want to begin by thanking all our partners for the overwhelming support that we have received during this transitional period. Transitions are always bumpy, like this one, but you have been with us despite the turbulence we have experienced, especially from an ICT front. Thank you, because when I wrote, you actually quickly were able to give service, and a majority of Kenyans are actually now happily getting service. You can be sure that this effort and this gesture will not go unnoticed. Now, I also want to thank you, because where you experienced problems, you are able to quickly and objectively give feedback. And using this feedback, we were able to make sure that we make various amends to our system. I am happy at this time to report that we have a breakthrough in our claims system. So shortly, we shall share a link that you will quickly upload in your devices. And when you upload in those devices, the good thing, I have gone through it. I've also had occasion to go through SMART. I have had occasion to go through MTBA, and I've had occasion to go through in Maria Life's SLED. The walkthrough feels like SLED. In fact, for me, there was no difference. So I am convinced that it will be a very easy system to implement. once we send the link in course of the afternoon. There is one question I would like to preempt as early as possible. With your help, and here I am borrowing from NHIF's experience with old e-claim. I am aware that we have continued to see patients, some online and some otherwise. My direction to the team is that as we are making payments after we come out of this turbulent phase, all these claims that we had are put into the system quickly, and they are prioritized because their documentation here and there may not be as complete as other cases, so that we do not have another case of old e-claims. So I would actually like us to agree right from the onset that all these claims that are happening now are handled as a matter of priority, and we get them off the way, even as we are continuing to pressure government so they are able to pay, and we release the payments that we owe providers as we move. So our commitment is to ensure that this system is supported to stability, and we have a way of making sure that we can move as much as possible. So my expectation going forward, and Hazel and team agree with me in this, let us have the new SHA Auto app after we learn it. Let us also have HICS app. And when a patient comes, they will be able to access service from either of the two. But the first effort will be SLADE. Will be this one that looks like SLADE. Then the next thing that I can actually say is where there are problems, all of us, ranging from our branch teams all the way to the director, are available to assist. And we covet that feedback so we are able to make a system that is excellent. It's giving service to all our Kenyans. Thank you very much.
Thank you, CEO, for the progress update. We appreciate your time and the communication that we've been having on the back end, just to keep each other updated on where we are. What we are availing is an army that can be used to disseminate information. However, I believe they have some questions of their own because of some of the things they are facing. I will request at this particular point so that we are able to move with in good time, that Musau, if you are in a position to talk, that you can quickly maybe field some 2-3 questions first. We have those addressed, and then I will jump to Mukua, then Liz, and then we'll come to plenary with the permission of the floor, so that we begin to tackle the big ticket items for the provider network. Karibu sana Msau. Msau is a chairman of Kenya Association of Private Hospitals.
All right, thank you, team. Thank you so much to the SHA team for availing yourselves today. I know, and as you mentioned previously, the rollout has not been as smooth as expected. So I could imagine the time and resources that have been spent into this. But diving into the questions, I think you've preempted one of the major questions that we had, and I think you've answered it conclusively. Maybe on that, we would request the CEO and the entire SHA team maybe to provide a guideline or a framework as to how these claims will be sorted out. Is it through what documentation is needed? Because most of these have not been captured in the format and in the standard that is expected for the normal claims that we have been processing under NHIF. So with that said, To my next question is, there are quite a number of providers who were not included in the list that was published by SHA. So there are some facilities that have been omitted, and they haven't been onboarded into this new SHA schedule of benefits, and some of them, even from the branches, have not been able to get access to their contracts. I think the CEO and the directors and other team members from SHA can explain to us what would be the status of such providers. And then finally, we have contract-related issues that we would like to get a lot more clarification on. To the best of our abilities, especially during the validation exercise, we were explicitly informed that co-payment will apply, but the contracts do not seem to specify this particular aspect, and a lot has been left to interpretation. Given the fact that a lot of members had requested for time to read and go through these particular contracts, this is one lingering question that we would really want to get clarification on. And once we get clarification, it should be stipulated in the contract in black and white, so that it's very clear to all members whether we have co-payment of services or not. And if we have co-payment of service, which services are amenable to co-payment? Are there services that are not amenable to co-payment? So I think I'll start with those few questions, because I know the rest will be covered as the conversation continues. Thank you.
Thank you, Musau. Hazel, also please advise on how you want to answer the questions. Do I collect them in batches of 3, 4, 5, and then we answer them and move to the next?
Thank you, Chairman. I was going to propose that since my CEO has another engagement,
okay,
these questions could be fielded directly to the CEO, so that at least once he takes a few questions, then he can leave for the next meeting.
Okay, great. So with that said, I will add just 2 more questions from Mokua, who's part of us here as well. And also in attendance, Dr. Gakombe, who is our chairman at KHF. Karibu sana, Doc. We will hear Mokua and then come to Dr. Gakombe for a brief comment and then go to CEO to allow him answer the questions. Mokua, karibu.
Thank you very much, CEO, Dr. Tim, and our CEO from SHA. We indeed appreciate your team is very engaged. I think 2 days ago, Hazel and a team of, I think, 8 senior managers at SHA held a meeting with us from 9 p.m. as faith-based, and we went through a long memo where we were asking for some amendments or improvements on the language. We've since received some feedback, and our facilities are now scrambling to sign and look for lawyers to witness and take our first drafts to the branches, because we didn't sign. We were still looking at the possibility of amendments. I think my first question then would be, or request would be that we have facilities that are a little bit far from where the SHA branches are. And we just got confirmation this afternoon and guidance that people can now take the signed contracts to the branches. And because it's a little bit advanced in the day, some of them will not make it to the branches to deliver the hard copies. And we will actually request that we make effort to ensure that all of them are submitted at least by Monday, close of business. So it's a request, and basically asking for that allowance from our CEO is here. Allow me to just appreciate that Hicks and the new provider claim system will all be opened at the same time. That clarity that we first make the attempt to make our claims and to admit patients using the new system. And if it fails, then we have a backup in HICS. That is the most excellent news. And I think because HICS has been here, it's operational, and now it has been even given the SHA logo, it shouldn't be too difficult to open that and give it the SHA tariffs actually, so that we can continue to see patients seamlessly without any hindrance. In fact, this is the only thing that is making it difficult for us to provide seamless transition. The HICS system being available to support the new system. Of course, once the new provider system has been tested and all of us are comfortable, we will have no problem at all, but transition over completely. Another matter, the second one, is CEO, we will always ask you this question. Would you prioritize the pending bills? Because now we are seeing an influx of patients. The promise is very big. We want to deliver, but sometimes we don't have commodities, we don't have drugs and so on. And so we will always ask this question every opportunity we get. Will we prioritize and pay the pending claims? CEO, I will stop there, and I appreciate the opportunity. Thank you.
Thank you, Moses. Mr. Wachira, I think we'll field those questions. The contract has received about three questions. One is that most providers are corporate, so there's some processes towards contract approval internally. So the request is on time. We allow some more time to the providers to go through the contract and possibly suggest some things that could be improved. The second one is on in this transition period, the management and handling of an adjudication of the claims by Dr. Musau, and co-payment terms in the contract as well by Dr. Musau. And the other one was the KMPDC list, I think, that is submitted to the authority. Some providers still say they do not appear when they come to the SHA end. Mukua has touched on the bills as well as the contract as well. The other request is to provide credentials to providers as we continue to provide services before the contract has been signed. I know there are some legal issues around this, but we are willing to providers and the authority to come to a middle ground that we both can honor. As you come in, Dr. Gakombe, if you're in a position to talk, you can say a quick hello, and we go back to Dr. Wachira.
Tim, I read from Dr. Gakombe, he's in a place where he's not able to talk.
All right, then you can continue.
I read from the chat.
Yeah. So everyone, please use the Q&A for the questions so that your questions are not lost on the chat side. That is a bit busy. Let's use the Q&A.
And I have also learned from Dr. Gakombe. In fact, I will first try. Dr. Gakombe says pre-authorization, in a sense, creates a contractual obligation on a case-by-case basis. So long as by pre-authorization is given, there is obligation to pay. Now, let me begin the questions as they came. And the first one is the guidelines on claims processing. My understanding of this is that the current contracts allow for claims to be reported within 24 hours. We are in times where within 24 hours, we may not have system all from the 1st of October, maybe 24 hours have lapsed and we don't have a stable system where we are reporting the claims yet. So the one thing that I will ask my team to do, once we have a stable system, then the providers will key in the claims that they will have incurred, and we shall, as a matter of priority, with your permission, first jump the queue. And I'm aware I am partially answering Mokua's question. First jump the queue and process this that have happened in a season of not very clear circumstances. Ensure these ones are processed and then go back to process the arrears when these are processed. So my advice is they will be put into the system once we have a system, and they will be paid off first. And then after that, we shall continue to pay the others. Now, the second question, providers not in the SHA list who have by extension not been onboarded, reading the SHE Act, it says that now the work of empanelment is now goes to the regulatory agency. So to that extent, the commitment I can give is once a facility finds that it is not in the SHA list, they should very quickly go to the regulatory agency. And once the regulatory agency fixes issues, we shall be able to pick the name from their portal, or they can even send us notification that this has been regularized. There's a case we observed in Kakamega where our Vihiga branch thought that this facility belongs in Vihiga. And therefore, when they checked Vihiga and they didn't find it, they reported that the facility is not in the list. But to KMPDC, the facility belongs to Kakamega branch. So as we are looking through, let's make sure that we are thorough so that if it is a branch issue, then it is something that can be addressed quickly. But right now, we have no powers to add anyone to that list. It is regulatory agencies that should do that. Contract-related issues. Indeed, we said in the tariffs that we shall allow co-pay. I saw it written there. So I believe the tariffs are part of the contract. They are an addendum to the contract, and therefore that co-pay is explicitly stated in the tariffs that are part of the contract. Facilities, now this one is Mokoa's question. Thank you, Mokoa, for the very kind comments. We value our partners and we shall ensure we listen to them even as we are making decisions. We are not a top-down organization. We are an organization that listens, and then we deliver what is mutually beneficial. Now, facilities from far-flung areas from the branches. My advice here is that those facilities, as much as possible, scan an advance copy to the branch so that as we are keeping tally of who has returned the contract and who has not, at least the advance copy will form a basis of our tally, even as now the hard copy will follow when it is convenient, maybe within 48 or so hours. I also note from Mokua and also from Dr. Theory that we have corporate clients, and therefore it has to go through a legal verification process. And my advice again around the same is, let us quickly tell our legal officers to prioritize this. I want to tell you why I am insisting that we prioritize the feedback we are signing. I have instructions from the ministry without fail that I publish on Sunday Nation, even if it will be 9 pages, all all providers that have returned their contracts, so that Kenyans will know where they can be able to get SHA service. I would feel very bad if I left any of the providers out on account of logistics and not on account of not agreeing with the terms of the contract. Mokua, around pending bills, I want to confirm to all that our commitment is to settle every obligation. If we have been paid amount owed to us by the central government, because it is generally equal to what we owe providers, we would be owing no one any money. Early this morning, I had a lengthy conversation with Treasury, and I was telling them, please pay up. My providers need to be paid. And I was told, we shall pay you something in the next 2 weeks. I have been told 2 weeks before. Sometimes it has been honored. So when I'm told 2 weeks, I wait for 2 weeks because itafika. And then after that, I either follow up or write a thank you note. So I am following up with every office. The SHE Act doesn't allow us to invest any money. So I benefit nothing from keeping the money in our current account. And if you have observed, every little money I receive, sometimes I send money even 3 times a month, because I would rather send you the little money, you find use for it, it will put out a fire, than keep it waiting for it to accumulate. My commitment and that of my team to all of us is that we shall continue remitting the money as quickly as possible. Thank you very much, and God bless you.
Thank you, CEO. I will pick a few questions from the Q&A section, and then fill them back again to you. I also request your team to also ably answer whatever they can on the Q&A, so that we are as comprehensive as we possibly can. Top of my head, we shall support any effort to get money out of Treasury, and I don't want to believe that is the next noise you will hear from us as the provider network. But secondly, we will request that even to the bosses at the ministry, and we're happy to also have that conversation with them, that the providers are interested in this to ensure that it works, because providers are the ones who underwrite the social contract that SHA has with Kenyans. And a few more days, 1 or 2 days, should not hurt much before the list can go out, so that there is comfort within the provider network into the contract that we are signing. Because as per the regulations, the next available time we can do this will be possibly 2 years from now. And from the way things are moving in Kenya, a lot is happening. And 2 years from now, we'll be staring at an election as well. So we will request that grace from your team. This is a question from Cecilia. CHPs are trying to sign on to SHA, but they are not an authorized agent. How do we help households to register? That was the first question. There is a question as well on the hurry from NHIF to SHA. So you'll also pick on that one. And then the login credentials, please comment on that so that we can have clear direction, even as we wait to submit the contract. There's also another question from Diana. Is there a contract for standalone dental clinics? Is there a contract for standalone dental clinics? And tied to this, CEO, is a question that is close to my heart. When shall we see dental benefits coming? I know you said in year 2. My hope is that we can see that coming immediately, so that every Kenyan is able to have a piece of the national cake and eat it. And then an explanation on the global capitation method. from George. So please take those so that when your time comes, we are able to release you. So the first one is on dental. We have
Thank you.
capitation as well as the login credentials.
Thank you, Daktari, and thank you for the offer to assist us in ensuring that the message to release money goes as high up as possible and is heard by everyone. We shall be doing it together because it's important that our partners, the healthcare providers, are well funded. How do you help a household to register? We have two methods of helping a household to register. Method number one, they can use a CHP locally. We have trained all CHPs on how to use the devices and register as many Kenyans as possible. Two, they can go to a SHA branch, formerly an HIF branch. We have trained our people to assist our Kenyans register. Three, if there is a sharp, like in my house, my son really likes playing with gadgets and we give him all gadget work. So if you have a sharp child like my son in the neighborhood, then he can actually be able to register everyone because he'll key in their ID and they will walk the journey together. Why the hurry from NHIF to SHA? The one thing that is very clear to many policymakers, to policy level, way above my pay grade, is that regardless of how long we wait, we shall never wake up and say we are ready to go live. So the desire is to go live, correct the mistakes, and start reaping the benefits of the good project now. Login credentials. Once we send out the link of the new portal, then we shall make sure that we send login credentials to all. And then immediately after, for those who will not have contracted, maybe before then, we invest in heavy training so that everybody will be able to appreciate how to navigate around the system. Then thereafter, we shall switch off anyone who will not be contracted so we can work with those that are contracted. So the questions on standalone dental clinic, dental benefits, and global budget provider payment mechanism, I want to request my colleague, Dr. Kuhora, to handle because he's around, and then also request to be excused because the next meeting was supposed to start at 3:30 and I have information that people are already here. Thank you very much.
All right. Allow me to thank you as you leave. We appreciate the time. Please have some flexibility, especially in the contract. That one we shall have a conversation on this side on how we go about it, and the rest we shall be left dealing on. Yeah. So asante sana CEO, pass our regards to the rest of the team.
Thank you very much.
Kuhora, karibu.
Okay, thank you. Sorry, I'm trying to multitask. I'll respond to some of the issues that have been raised or what the CEO has just mentioned. On the issue around standalone dental facilities, there are those products that we are not expecting to start immediately or from 1st of October. They're expected to be rolled out later on. So the dental product is one of them, and that's the reason why for standalone dental, they're unlikely to be in the panel that is there in the contracts because of the period of the rollout. Then the other issue that I think I've heard and I've also seen in the questions is just an elaboration of how the global budget is meant to work. The global budget is just a method of payment where money is allocated to a PCN depending on the population that has selected that PCN as a place they would want to access the primary healthcare services, specifically the outpatient. Then within the PCN, we have providers. So the selection of that PCN is what is used to allocate monies to that PCN at the rate which is has been provided in the contract, which is 900 shillings per person per year. Then the reimbursement to the facility is drawn from that pool that has been given to the PCN. So the reimbursement to the facility is basically the formula that has been used is the numbers in terms of the total number of visits to that PCN in a quarter. And then that is multiplied by the weight per disease. Now, the reason for the weight per disease is that when we looked at the capitation data, there are some facilities where the services being offered as outpatient are skewed towards the services which on average are a lot more expensive. So the weights per disease category is basically to try to protect some of those facilities which are seeing more of the stroke cases as opposed to pneumonia cases, because on average, an outpatient visit related to stroke is going to be more expensive than one related to a pneumonia. So that's how it's meant to work, and it's entirely dependent on the system, because everything is system generated. And one other thing that is different is that the allocated amounts are reimbursed to the provider every month. So you don't have to, it's not an upfront payment, but the reimbursement is made at the end of the month once we have the visit data. Of course, it has its advantages and disadvantages. One of the advantages is that the PCN or the providers within the PCN have to work jointly. Otherwise, it's going to basically mess up the deliverables for the other facilities within the PCN. Then two, which is the same as capitation, is that it basically distributes the risk and reduces the risk for the payer. Now, one of the disadvantages is that if the visit rate is high for whatever reason, the visit rate within a PCN is high for whatever reason, either there's an ongoing epidemic or something like that, then the average reimbursement for the providers is going to go down. So it's going to be a sort of a disadvantage. I'm saying sort of disadvantage because when the visit rates go high, then it's the PCNs need to, or the facilities within a PCN need to take initiative and engage the population at the community level to be able to reduce that. So because the HCPs are linked to a HCA and the HCA is linked to a facility, then it means that that flow between the community and the provider is meant to work using this method. Are we anticipating challenges? Yes, we're anticipating some challenges in the initial phases, but eventually that is how it is meant to work. So I think unless now there's something else that needs clarity, but the figures are there, and how it's meant to work, the simulations are also there. We can share that.
Allow me to ask a quick question, Dr. Kuhora. There are some facilities looking at the model of reimbursement and the model of operation of PCN that makes it untenable to provide care at an outpatient level. For example, looks like this is going to be what you call a high volume business. Facilities allowed to opt out of some of the packages that are being provided, and for level 2s and level 3s.
Okay, so the issue is, are you allowed to walk out of some of the benefits?
Yes, like let me start with the PCN one. I currently level 2, 3s will be allowed to provide emergency care. And we understand that emergency care has a different mode of financing than the primary health care. And maybe a facility is not interested in the primary health care or being providing primary health care within the PCN network, but would like to have that provision for providing emergency care. So are they allowed to sort of choose what they can work with and what they can't work with?
Okay, thanks. I think I've gotten you. There's a criteria which we can share after this meeting. We are calling it the product mix criteria. It's not the first time that we are using it, and that is for the benefits which are basically conjoined twins. They are joined at the hip. Then you're not allowed to select one and leave the other. An example is you cannot be contracted to offer cesarean sections, and you're not contracted to offer normal deliveries, because it skews the quality indicator that we are looking out for. The same way you cannot be contracted to offer. Now, when it comes to dialysis, there is the provision for having a service level agreement with a provider who has an ICU. The reason being, most of the providers are actually standalone providers for dialysis, and therefore it's not expected that you will have an ICU within a dialyzing unit. So there are those benefits that have to go together. So if you drop one, then you basically have to drop both. But I think we can be able to share the criteria so that it becomes clearer on that question and also any other that are related to the product mix.
Thank you for that. Just on the same line for clarification, when it comes to patients who are being admitted in inpatient care, let's say a mother is being admitted to a level 4 hospital for normal delivery or a cesarean section, will they need to go through the referral system that has been established at the primary healthcare level?
No, for the referrals, it does not apply when it comes to maternity. And there are also a couple of other benefits where it doesn't have to go through that chain. The referral largely applies when it comes to the outpatient because of the aspects of trying to strengthen the referral framework within the country. Hopefully, we'll get to where NHS is with the HMOs in the UK. But for some of them, like deliveries, it doesn't have to follow that. For issues around the more complex management, it doesn't have to go through the primary.
So I think, sorry.
Eric, you can finish, but I wanted to ask a question closely related.
Yes, so I think what we really need are those granular explanations so that we are able to know, because remember at this point in time, we are more or less operating on goodwill basis. We don't want to come, that time that the CEO has talked about, then we have variations to these discussions where we are being told this ought to have gone through a referral system, therefore it is not payable. So we would like to get those granular clarifications. We need to know if a patient is coming in, say, for an appendicectomy or is coming in for laparotomy or whatever it is, do they need to go through the referral system? And so on and so forth. So if that can be explained in granular, I think that would be better, and it will also ease a lot of member concerns moving forward. Thank you.
Yeah, I can follow up.
Thank you. That's noted.
Dr. Kora, so there is a patient going to level 5, and they haven't gone for patients, but they choose to pay cash in level 5 for consultation, and then the doctor determines that they're at a level that they need admission actually, but they are also paid up SHA members. If the doctor admits, will SHA cover the admission expenses, at least the rebates section? Back to you, Dr. Kora.
Sorry, I had not unmuted it. So yeah, in such a case, that patient flow would be quite straightforward. The thing is that you need to maintain the adequate documentation on the consultation and the diagnosis that has required the admission or the procedure that is being contracted at level 4, 5, and 6.
And that would apply for surgical cases as well, because some of them come and they are clearly going to theatre soon after, but they might come
Yes.
straight to level 5.
That would apply, but you know the risk that is there. Therefore, there is going to be quite a lot of scrutiny when it comes to the pre-authorization because of the risks. There are, of course, there are inherent risks. Otherwise, all cases presenting even as outpatient are going to be reported as inpatient.
Okay, appreciate it.
Thank you. I will pick the next set of questions. I will begin with, I'll also request that Kuhora, if you can, as well as Wafula and Joseph, that answer as many questions as you can on chat, as Kuhora is the man on the floor, as I have been advised by Hazel for the moment. So the global capitation has been answered. So there are 3 questions on bed rebates. How do we get that? But more importantly is the question on the platform is only allowing for employers 1 KRA number. So the SHA employer portal can only accept 1 time use of the KRA PIN. What happens to a group of hospitals? So that is the first question on the use of the KRA PIN for single use. The other one is by Shikuku. Are we able to get a guarantee that we shall either have HICS reinstated and with a guarantee that pending request, once pre-authorized, shall be promptly approved for service continuity, or the new system and its credentials shall be shared along the same lines. Rebates and surgeries are currently on hold and patients are on cash. So Kuhora, those, I think, 3 items, and then I'll come to the next set of questions.
Okay, thank you. For the KRA PIN, let me just get back to you because I think it has been raised in one of the doctors' forums. I've seen it in one of the forums that I'm in. It was also raised by some of the branch managers on Monday and Tuesday. So I need to find out whether the system configuration has been made to allow for 1 PIN to be used across different facilities. But it's a request that has already been made to ICT.
Thank you. The other question is on claims that were there before 30th September. What happens to them? What will happen to the pending LOUs from the NHIF system requested before 30th September and haven't been approved? Patients received the service. What happens to LOUs before that have not been approved? Sorry, and patients have already received the service. That is from Nahala. And then the second question is from Shama. What is the process to submit the bills, who to submit, and how to follow up? Bills, as a submission of bills, I think claims, if I may call it that. And those could be different actually. So I'll just ask the question as is. Process to submit the bills, who to submit, and how to follow up. Uhora?
Okay, thank you. On the issue of pre-authorizations, currently we have some directives in terms of the processing of pre-authorizations, so none of them are being done at the moment. But then we had made a request based on the pre-authorizations that had been made before the 1st of October, made and approved, but not yet done, because that patient will require to be admitted and discharged before that pre-authorization is used. The issue that has been raised in this, it should not be the ideal, because ideally the procedure should be done after the pre-authorization. but we are aware of circumstances where that is necessary. So we need to have those ones submitted. Just to respond to that and the next question, there are these inherent things that we are likely to come, they are likely to come in terms of who processes what, the formats that are being used. I think you raised that during the introduction session, and who they are submitted to. So there's a team that Wafula will be heading, and they are presenting, they are meant to work on the key areas of intervention. I think we had identified about 13 or so, but we'll narrow this down to about 5 or 6 procedures that need to be clearly elaborated, and the forms or formats are submitted to the different providers. So it's a priority area, and we're expecting to have some working document being reviewed and probably sent to the providers by Monday. But it's something that we discussed on Tuesday, and it's being worked on at the moment. Over.
Thank you, Samson. The other question is on the Sunday publication. Is it illegal or just a matter of informing the public? For sure, I think it's just a matter of information. If I got what the CEO said correct. How will clients access benefits under Linda Mama? Is it under SHIF where the client must be paid up, or is it a separate fund, or is there a separate fund from it for it? This is from Collins. Linda Mama, is there a separate fund for it, or is it from SHIF? The other one is from Anne. What is the procedure or payment mode to be used for self-employed? Is a pay bill 222 still? And then I will ask the last question for this round so that you take them. Is there a specific timeline for settling of bills by SHA? That is from November 2023 to date, after starting the collections from the new contributions this month. A solid timeline for this will be great. That is from Shikuku. And there's also tied to that the question of historical and paid claims. Over to you, Kuhora.
On the issue of Linda Mama, I'm seeing Joseph is typing something, so he's typing a response. Then now, on the issue around 222, I think this one has also been raised because the platform for payment of premiums for the informal sector, apparently for most people is still not clear. So there are some flyers that are being developed by corporate communications, and that should explain the process and also the pay bill numbers to use. There have been challenges around this specific number 222 because remember, this one is as part of the member portal. The member portal is linked to a contributor portal. A contributor portal is linked through an API to the eCitizen. That is what completes this cycle to pay through 222. Now, since the member portal is expected to change or has changed, that's the reason why some of the transactions might not be going through. But then I think there was a provision that was there was an approval that was given that we could still reactivate what we were using before, which was 222 until the issue with eCitizen is sorted out. I'll just seek a clarity on whether that position has changed from the director ICT before I give an adequate response on that. On the settling of bills by SHA, for the accumulated bills or the historical bills, we have gotten all the data from the system. Then we'll take it through another reconciliation process because we don't expect any other claims that are related to that period. The reconciliation process basically categorizes the claims into three. There are those ones which are authorized accounts and are due for payment. So how soon that is going to be paid will be dependent on the funds availability. And I think the CEO has mentioned that we've been engaging Treasury. just to make sure that the pending premiums in government-supported programs are actually paid up so that we can be able to settle all the claims. It's expected that if all the amounts are received, then the full projected numbers would be paid. Then we also look at the ones which are in receiving stage. That is what ended up being misclassified in one of the articles of one of the complainants to Parliament, which we usually call the IBNR. IBNR are basically incurred but not received claims. So we appreciate that there are those ones in the process. The service has been offered, but it has not been physically received for processing. So we have to make a provision for that. Then there are those ones which are being processed at the branch level. So we make the provisions for all those things. Once we do that, we'll be able to communicate to the providers. At the moment, we've done it per branch, but then we'll be able to narrow it down to the specific facilities. And then we have a joint reconciliation process. So if you have different figures, then you provide the evidence and we clear with that. The timeline for doing that, we are constituting a team, and from the terms of reference, we are expecting it to be done within 1 month. So that means by the first week of November, the submission should have been made to the NHIF board. Then the NHIF board is meant to discuss and pass it on as liabilities to the SHA board. Then for Linda Mama, the same. I think we already have everything that has been profiled so far. And one of the challenges that we are likely to have with Linda Mama is that they are pending premiums from government, because this is a fund, we don't do cross-subsidization. So the amounts that are settled for Linda Mama actually depend on the amounts that have been received from government. And since so far for Q1, nothing has been received. And then for the last financial year, there are still some pending bills. So that one I might not be able to give clear timelines, but one of the key things that we intend to do is to reconcile everything and they agree on the liability that needs to be passed on. And the timelines is basically within the next 1 or so months. That's the period we've given ourselves. For the incurred bills, I think the contract provision still stands at 90 days, but we are expecting that this is going to be a lot faster, because we know that we have an estimate of 20 billion shillings that is payable bills that have not yet been paid. Therefore, we don't want to accumulate other bills. So the initial projection is that I'll need to liaise with finance, find out the bills that are presently available, make sure that within this period when we are still using manual methods, we have communicated the tools to use, and then give some guideline in terms of how to process those claims, as I explained earlier. And all factors kept constant, I think we should be able to make the first batch of payments before the end of the month. Over.
Thank you. I will start from the bottom coming up this time so that we sample everyone. There's a very interesting question by Fadis. Members will access service across a network, hence no person will be capitated to one facility. Reimbursements will therefore be based on workload. How will workload be determined if the SHA provider portal only allows for determining eligibility and not services offered? So just read through that for us so that we are able to answer it very well. And then there is a question on foreigners who are in employment. People are not able to onboard them. So what is the procedure for that? And then there are also patients who are termed as refugees as well. We are unable to register for SHA. Some of these patients had LOU approvals for dialysis beyond 30th of September. And then the final question from the bottom by Leonard is that what line of treatment is level 4 allowed to admit in general ward? Do we have exceptions? So take those, Dr. Kuhora.
Okay, thanks for that. I think I'll start with the last one, that the first one that you mentioned from Fanis. This basically explains the global budget, how the global budget is meant to work. So the member selects a PCN, that is the network. And then the monies are allocated to the PCN depending on the number of members that have selected the PCN. So if you have, let's just give a scenario. We'll call it PCN A. It has 10 different providers, and it has, let me say 100,000 people who have selected that PCN. Therefore, the allocation per year would be 100,000 times 900, which is the estimated allocation. Yeah, so that comes to about 90 million. So 90 million, we just do small worksheet. So the 90 million would be this, basically it would mean that the facilities within that PCN would be entitled to about 7.5 million shillings per month. Because as I mentioned, we are intending to move these to per month payments. So the facilities within that PCN are entitled to 7.5 million. Now, if these 10 providers generate maybe 1,000 visits, and then for each visit has a weight. For example, pneumonia has a weight of 1. But for a disease which is a lot more complex to manage, it has a higher weight. And I think that's a document that is available. We can be able to probably have some discussions on it. But there is what has been adopted in terms of the weights. So let me just see whether I can access one. So that would mean the 7.5 million will be distributed to the providers depending on the total number of visits in that particular, or rather each visit times the weight of the visit, and then you sum up everything for that particular PCN. So that is what will give the total amount that will be due to each facility. So if the total number of visits times the weight is maybe 20,000, and the weight for a particular facility in terms of the visits and the diseases is maybe 1,000, then that facility will be entitled to 1,000 divided by 20,000. That is the weight for the facility times 20,000, which is the weight for the month for the PCN, multiplied by 7.5 million. So as I mentioned, there are anticipated challenges. I think during one of the forums, it was one of the providers made it very clear that it's very uncertain, and a provider might not even be able to estimate how much they would be able to generate. So those are some of the challenges, but we are anticipating that when some things settle down, we'll be able to have a better understanding on how it's meant to work. So as I mentioned, I'll just give an example. The weight for pneumonia is 1. The weight for cholera is 1.05. So that is the difference between the two. The weight for typhoid is about 1.14. So it varies depending on the batch of diseases that are being managed. Then there are those ones which are cheaper than that, either because we don't expect significant management at that level, or on average, the cost of management at that level is lower. So that's the reason why the weights are a bit different. Over.
Thank you. So we are approaching the 1 hour mark. We'll maybe continue for some 10, 15 more minutes. My request will be to Martin, who is checking the back end. Please ensure you pick all the questions so that at the close of the meeting, we're able to supply them to Kuhora and Hazel. and Wafula as well for their answers, and we'll post that in the general NHIF providers group, as well as on the HF platforms as well, and supply them to the representative associations. What I will also request that possibly maybe on Monday or Tuesday, we have a second session where we will have most of these questions come in and see the progress between then and now. I will go back to the top. Historical claims we've answered. Previously admitted patients and HICS does not support pre-authorization at the moment. For LOU, what happens? And then
For the
other
patients who had been previously admitted, the system allows for the discharge. It's one of the things that we had to do on day one because there were a couple of facilities which detained patients because the system was not expecting any transactions, or rather, no transactions were going on in the HEC system. So the discharge is possible, but the admission is not. So if a patient had not been admitted, then it's not possible to do a discharge within the HICS at the moment. So as I mentioned earlier, we are doing the working documents, and then we'll give a direction in terms of what you need to do, especially for the providers who went ahead and issued or offered the services before an actual approval was made in the system. Because I think that's one of the things that have been raised as one of the questions here. Then there's the issue about foreigners or refugees being unable to register. I've also taken note of that because now we need to engage ICT. But as per the legal provisions, anybody who has the ID number, passport, alien card for refugees, they should be able to register.
Asante. There's a request from Cynthia for a dedicated support team for the technical challenges faced by the facilities and registering as employers on SHA and e-contracting. I think it's quite a valid request. So please work on it internally, Dr. Kuhora, so that we can have a link person. I'd want to believe for easier distribution of the workload, if we have equally trained people on our end, we should help tackle most of the questions and concerns from the providers. I know RUFA, CAF, as well as KHF would be each willing to provide at least 2 people so that we are able to distribute the load amongst ourselves and make it easy for the providers. So please prioritize, even if it's a trainer of trainers, that we have representation from the provider network as well as the faith-based organizations. I think sort of related to what had been asked, if you feel you've answered it, you can skip it, Kuhora. The new SHA tariffs already affect already existing HICS approval. Do the new SHA tariffs affect already existing HICS approval at the time of admission and discharge? I think you've sort of tackled that question, but you could add some more information. What will happen to radiotherapy approvals where patients had received a certain number of fractions before 30th September? And then the final one for this round is what line of treatment is level 4 allowed to admit in general ward? I think that one I had asked, sorry. And then there was a memo for dialysis for providers to continue offering care to patients. The reimbursement rate is as per old contracts or as per the new benefits package. So take those ones. Over to you, Gora.
Okay, thank you. For the previous approvals, the ones which were running, we have made a request that they be reimbursed at the current rates. You just need to maintain the adequate documentation because of the limitations in terms of the system that is being used. For level 4s, I will request to send to you a document. This is a gazette notice from the Medical Council, and that is what we are using to give the matrix that a provider will be able to access. So this is a special issue that was done by the Medical Council as per CAP 253, and this was done on 31st of December 2021. So it gives the categorization of all the providers. I think I responded to one of the questions that categorization is not done by SHA, it's done by the regulators. So it gives level 4, it recognizes a primary care hospital. As 4A, it recognizes 4B as a specialized medical or dental clinic. It also recognizes 4B as a specialist home-based care service or hospice, or a specialized or specialist eye clinic. So those are the categorizations that are there, but I'll forward to you the Gazette notice for your reference and probably sharing in other groups. That's why we've been insisting in the different groups. Kindly, if there is any variation in terms of your contact details or in terms of your level of care, you need to engage the medical council so that some of these things can be edited from their side. After all, even when the new superhighway comes into play, the health information exchange as relates to the provider is going to be drawn from the medical council. So you just need to make sure that your data at the medical council is accurate. And then I think there was a third question I might not have written it down.
It was on, let me just go back up to where it was. I think you've answered it. I think you picked it up. Nathan still feels the question on discharge has not been addressed to completion. We have those discharged that need approval of bills spent up to the night of 30th. How do we go about this? Those who had been discharged and the bill needs approval up to the night of 30th. And then some hospitals have been wrongly categorized. That has been answered. Will the newly registered patients be automatically onboarded, or there's a wait time? So pick those two first.
Okay. In terms of the waiting time, it's not anticipated that there will be a waiting time. Presently, the wait has been for 90 days. Of course, it presents a risk, especially on adverse selection, but that's what the law provides. Then for the claims, I've taken note. I think even the webinar chat has quite a bit of questions, especially on case code 30. So I've taken note on the issue of case code 30 because it's not just about discharging, but there's also an approval at the point of discharge. So I will engage with the case manager on the way forward because we had a meeting this morning and it was one of the areas that needed to be activated so that they can be able to discharge. On the webinar chat, I've also seen a question on why NHIF needed to be wound up. I don't think my pay grade allows me to answer that. We'll just say that that's a legal provision and that's the direction that the government has taken. But I think in the different forums that we've sat, we are aware that there are key challenges. One of them being the question of the informal sector. So if we don't address the question of the informal sector, we are likely to face the same challenges that NHIF has had. And the two is on the issue of chronic conditions. It's one of the areas where we have significant out-of-pocket payment. We've profiled 63% out-of-pocket payment for cancers, 49% out-of-pocket payment for cardiovascular diseases, about 47% out-of-pocket payment for diabetes. So those are the things that we know have been a challenge, and we are hoping that they're going to be sorted out in the new dispensation. Yeah.
I think just two more in the interest of time. Moku has asked patients who come direct to level 5 and pay for outpatient, can they be admitted under SHA? And then there was an important one by Caroline on oncology. Under the oncology package, the previous, I did apologize. Oh, Mukua, I was reading the one you'd written. All right, so let me just go to the oncology one, and then we have Kuhora Cup, and then anyone who's on the panel, if you have a burning question, we'll field them. And then
answered. He
okay.
said it.
Okay. So under oncology package, the previous contract had benefits for basic chemotherapy at a maximum of 25,000, complex at 100. The current one does not specify. It only gives limit per household. Advice on that, Dr. Kuhora. And then why does level 3B not have delivery on CS package? So pick those two, and then the rest I will request Martin from my side to pick them, and we'll forward for answering, and we shall send the same to providers. Over to you, Kuhora.
Okay, thanks. I'll start with the last. For 3B, why it does not have maternity, I'll refer you to the document that I've shared on your WhatsApp. On the Gazette notice by the Medical Council, it clearly defines what a 3A is and the scope of cover, or rather the scope of services that they are meant to offer, and also a 3B and a 3C as well. So if you look at the scope of services for 3B, it excludes anything other than the outpatient or the day procedures. So our request here would be for us to engage with the Medical Council when it comes to categorization, because they're the ones who are handling that. They're also the ones who are handling the empanelment. Now for oncology, our main change, I would say it's one of the areas where we have significant changes in terms of the benefits. We've been covering what was being called basic chemo and complex chemo. And then we've been capping in terms of amount per session, and we've also been capping the sessions. Based on the discussions that we've had with the different providers and also key stakeholders within the oncology practice space, there has been a key change that we need to finance the cost of treatment and not sessions of treatment, because what happens is that when a patient cannot afford the treatment costs, then they basically default. And by the time they're coming back, it is a more complex case where we end up spending more. So the provision that has been made under oncology is that we cover for diagnostics and staging for a maximum of 100,000. We are anticipating that most of the diagnostic tests and also tests related to the staging will be covered within that. Then we also cover up to 300,000, regardless of the cost per session of treatment. But then we have guidelines, we have treatment guidelines, and we have a formulary that we have developed together with NCCP and also KESHO to be able to guide how much each session is meant to cost. So those are the checks that we are putting in place, but then it has a limit of up to 300,000. Now, one of the requests that we had made to government under the ECCF is to cover an additional 600,000, 650,000 to be specific, when it comes to oncology under the chronic diseases. And that was meant to make sure that more than 99% of the cases will have the full treatment cost, unless now it's for more advanced types of treatments like immunotherapies. But then because of budgetary constraints, that is unlikely to be rolled out immediately unless there is a significant allocation from Treasury. So what we are sure of is the 100,000 related to diagnostics and staging, and 300,000 related to the treatment. But it's not limited when it comes to the amount per session. But the pre-authorizations will be able to reconcile the document that we have with NCCP and KESHO as far as the cost of treatment is concerned. Over.
Thank you. Difficult as it may, we are coming to the close of the session. We've been at it for around about maybe an hour, 30 minutes. The weekend is here with us. A couple of things that need to be taken care of for sure. by both teams. So with a lot of humility and patience from you, I will request that we begin to close, avail the recording of this webinar so that you're able maybe to walk through with your teams as the questions were answered. And so that's why we want to keep it maybe 1.5 hours, which is the time for the average movie for you to be able to follow later on. Is there any of my panelists with a burning issue question that you feel you want to say at this particular moment? All right. The FIFA rules shall apply where silence consents for progress of the meeting. So to everyone who's been here with us, all over 300 of you, we really appreciate. The notice was indeed very short. We'll attempt to make the Tuesday meeting or the early next week meeting on good notice. I will circulate the notice on time so that you're able to participate. I receive kind regards from Dr. Gakombe, who is the chairman of PHF, and the chair of RUFA, Dr. Lishenga, who could not be here with us. The general secretary of CHAP, Dr. Mwenda, also passes his regards. I don't know whether the CEO is still there. If not, Dr. Kuhora, with your permission from your end, we can close this and look forward to Tuesday. Dr. Kuhora, we are good to close.
Yes, thank you. I appreciate your feedback. We might not have been able to meet everything, but we'll collect what is there in the chat and what is there in the Q&A. And when we have the next engagement, hopefully on Monday, we'll be able to appraise ourselves on the situation. We are hoping that the status would have been improved for the better. And if there is any pending questions, we'll be able to respond. I think the providers can seek to interrogate the Gazette notice that we've shared so that we see whether we need to have an engagement with the medical council. But that's basically the reference document when it comes to the scope of services by the level of care. Over.
All right, excellent. I will request that you just people remain on board just for a few minutes so that I'm able to share that particular document on your chat for everyone to see it before we close down the meeting, for everyone to have a copy of the same. So just give me 1 or so minutes. Yeah, so everyone should have it on their chat. It's uploading. We will keep this live for 30 or so more seconds so that everyone can have that document. It's a guidance from KMPDC. So give us feedback. Dr. Elizabeth, who was earlier on here, and myself also sit on that side of KMPDC. So we'll also take feedback and work closely with SHA so that we are able to ensure that the provider network is well taken care of. All right, without much ado, it's 4:24 on a warm Friday here in Nairobi. Thank you so much for being with us today. We will close down now and wish all of you a lovely evening and a good rest of the weekend. So the document will remain, the session will remain live for maybe 30 seconds so that anyone who's not interacted with the document can do so and download, and we shall close down the webinar. Thank you so much. Pass our regards, Dr. Kuhora, to Hazel and CEO. I know they've gone for the other meeting. Asanteni.
Thank you.